Today's feature presentation. I'd like to introduce to you today's speaker, Melissa Gordon-Pitts, MSW, LCSW, ACM-SW. Melissa Gordon-Pitts works at Duke University Hospital as an Assistant Director of Clinical Social Work. Formerly, she was a social worker at Duke's Adult Sickle Cell Clinic, where she provided counseling and support to her patients in the clinic and hospital. Melissa provides cultural sensitivity and trauma-informed care training to medical staff. Teaching is one of her passions, and she has provided training on a variety of topics, including historical trauma and its impact on African American patients, how to have difficult conversations about race and systematic racism, implicit bias, and its impact on how to communicate. Melissa is currently a faculty member with the American Society of Hematology. Melissa obtained her bachelor's degrees from the University of Maryland, Baltimore County in psychology and social work, and she graduated from the University of Maryland School of Social Work with her master's in 2001. So without further ado, Melissa, I'll let you take it over.
Hello, everybody. I'm so glad to be here and so excited to have this opportunity to share and present with you. As it was said, I'm going to talk to you about historical trauma and providing trauma-informed care to our patients. Next slide, please. So our learning objectives, we are going to define what historical trauma is. We're going to take a look at how trauma presents in our patients and our provider relationships. So sort of how it rears its head, if you will, how it presents itself, and then how it kind of plays out in our partnership with one another. And then we're also going to learn a trauma-informed approach to patient care. Next slide, please. So this is normally the part of the program where I say, by show of hands, how many of you have ever heard of historical trauma? But I can't see your hands. So instead, I'm going to assume that some of you are familiar and some of you may never have heard this concept before. But historical trauma really gained some ground and footing when we were studying survivors of the Jewish Holocaust. We were trying to understand why we were seeing some of these behaviors, some of these patterns, different things that were happening. And we quickly realized that there's actually a term. We gave it a name, we gave it a term, and that term is historical trauma. And we also found out that it is something that has actually impacted many, many people. As we understood what historical trauma was, we were able to apply the findings from historical trauma to different groups. But what it is this collective and comprehensive trauma. So this big event that took place across a period of time, across generations, that has impacted people. It impacts how they share people who share the same identity, the same cultural affiliation or group affiliation, or the same circumstance. So it doesn't always have to be culturally based. It could be based on a war that took place or colonialization, for instance. But we also know that it has impacts on people of color who have experienced Holocaust type or persecutory types of events, as well as African Americans here in our country with slavery. Next slide, please. So historical trauma is cumulative and collective. It's this event, because this event happened, it has an impact not on just the generation that it happened to, but is also passed down to the generations after that. The impact of the trauma, it manifests itself emotionally and physiologically within a cultural group or a group of shared experience. And you'll see a lot of the research that's been done on historical trauma, if you want to dig in a little deeper on it, has been done by Dr. Braveheart. A lot of her work is going to help you to learn more if you want to kind of dig in. But it does affect many generations after the trauma has taken place. And oftentimes that trauma is transferred down through things like storytelling. For a lot of cultural groups, telling stories, sharing experiences is a huge part of how we transfer information from one generation to the next. There's also some genetic components that we're trying to study and understand a little bit more. Beliefs about ourselves and others is something that happens as a result of historical trauma, and we'll dig in a little bit more with that soon when we start talking about that trauma-informed care. And then unfortunately, especially here in our culture, here in the United States, for African Americans, there's this continued victimization and racism that we just see play out over and over again. That certainly does not help, but actually adds to that trauma. And then we know that groups that have experienced historical trauma oftentimes are left sort of marginalized. There's issues with lack of resources because of that initial trauma. Next slide, please. So why is historical trauma relevant? Why is it important for us as a team to look at this and to think through it? The impact and the results of the trauma are felt for many generations, as we've talked about. And survivors can develop and internalize a lot of negative views about either the folks that inflicted the trauma, or what we'll call the oppressors here, or these dominant cultural groups. And when we have these sort of internalized negative views, it can manifest in the work that we do. And we'll talk about how in a little bit, we'll talk more about what it looks like for African Americans in the healthcare system and sort of the generational trauma that has even happened there. Survivors can begin to develop and internalize even negative views about themselves and their self-worth and their value based on what has been inflicted upon them. And then anger and hatred can develop towards dominant cultures, or even turn inwards toward ourselves within our own groups or within our own individual selves. So we will think more about that. So this is a graphic that helps us to understand why and how historical trauma kind of builds on itself. So there's the trauma that happened at the base, and then for many of us, we may know what adverse childhood experiences are, but these are they sometimes will refer to them as ACEs, but these are difficult challenges that hit us early on in childhood. So whether it's poverty or lack of good educational structures, or lack of housing, lack of good nutritional diets and things like that. Oftentimes, as we talked about, when that trauma happens, it kind of pulls down some of the access to resources, so it leaves us with these adverse childhood experiences. We also know, and we'll talk a little bit more in a moment, about disrupted neurodevelopment and what happens with trauma in the brain. And then we also see that it then leads us to adapting socially, emotionally, cognitively, how we engage with others, how we see ourselves, how we view others. And when we start to adapt our thinking about things, it can lead us to some risky health behaviors, right? Sometimes you'll hear folks say, like, I'm not going to take those meds because I don't understand, or I don't trust that this is safe for me to do, or I'm not going to follow the plan of care given because I don't know that this plan makes sense to me or is comfortable for me. And then what it does is it just kind of leads to further disease progression, and then unfortunately it can lead to early death. So we know that historical trauma has a significant impact on folks, and hopefully by the time we're done talking today, you'll understand what we can do to prevent a lot of that and really work through that trauma. So when we think about some of the medical related trauma that has impacted the African American community, one of the things that jumps out immediately are the Tuskegee studies, and the fact that African American men were given syphilis without the treatment. We knew that that penicillin would work, but we chose instead to let the disease play out for us to run our research and do our studying. And oftentimes I will hear and have heard my patients say to me things like, "You're not going to experiment on me," and I immediately know where that came from. I know that we're thinking about that historical medical abuse that took place within our community. Next slide, please. Another example of that early medical trauma, many of us may know about Henrietta Lacks. This is a woman who died at a very, very young age of cervical cancer. And as you heard from my bio, I'm originally from Baltimore. I did all of my education and my early childhood growing up there. And so at Johns Hopkins Hospital, which is a huge hospital in Baltimore, in the middle of downtown Baltimore, there were tissue samples removed from Mrs. Lax, and this was done without her permission, without her consent. Some incredibly detailed research was done, and the doctor that took those samples became famous for his work, but never honored, up until just a few years back, honored Henrietta and her sacrifice, but again, done without her consent. Next slide, please. And some of you may also be familiar with eugenics. This is this idea that we're going to create the perfect human population by breeding out undesirable traits. And to be clear, a lot of those traits had to do with sort of that blonde-haired, blue-eyed kind of a preference. And for people that didn't quite match that, then the idea was we could deem you feeble-minded or come up with some reason why you should not be able to procreate. And against people's will, we were actually sterilizing folks. And here in North Carolina, which is where I now practice social work, we had eugenics laws on our books up until 2003. There are current peoples that have survived having been sterilized who are just devastated because they did not have the opportunity to have children. And let's be clear that people of color were overly represented in the eugenics movement. Next slide, please. So we know that there is a lot of history when it comes to African Americans in healthcare. And when we think about trauma, I want us to transition from what has happened to how it has happened to us in the sense of how it impacts our brain. On this slide, you'll see that there are many ways that trauma can impact the brain, but the two pieces of the brain I want us to focus the most on are the amygdala and the hippocampus. So with the amygdala, this is, for those of you who may remember, this is the fight, flight, or freeze portion of our brain. So when a child is born, this is the part of their brain that's going to work automatically. I will say when I am stressed out and overwhelmed, it's the part of my brain that kicks in because you don't have to think about it, right? That part of your brain is that sort of primal early age piece that whether I think or not about it, it is going to kick in and it is going to do what it needs to do to protect me. And when that amygdala kicks in, we see that fight, flight, or freeze. You're going to hear me talk about that over and over again because that's going to be important to what happens with trauma. When we have experienced an intense amount of trauma, whether it is historical trauma or present trauma, and it's important that we realize that there is also present trauma, things that our patients go through on a day-to-day basis, whether it's something like a house fire or the loss of a family member or some other traumatic event, that there is past and sometimes present trauma that exists. The brain does not determine or decipher between past or present. When it is overwhelmed with a traumatic experience, that amygdala is going to kick in. You're going to see fight, flight, or freeze types of responses when someone is feeling traumatized by something that has happened to them. The hippocampus, on the other hand, and actually we can advance to the next slide, so I think my next slide is a whole slide about the hippocampus. Oh, nope, it's not. Okay, that's okay. Thank you for going back. But the hippocampus is the part of our brain that handles like emotional regulation. And so if we have been through a lot of trauma, we find that the hippocampus, and when we do brain scans, has actually gotten a little bit smaller. It does not function in the ways that we want it to be able to really control a lot of that emotional regulation. And so if my hippocampus isn't doing what it needs to do to keep that amygdala in check, then the amygdala is going to take over and I am going to be reacting and responding to the things that are around me in whichever form of fight, flight, or freeze tends to be my sort of go-to. And by the way, we all have a default. terribly enough, my default is freeze. So I am in a bad place if I'm ever in trouble, because I am just going to stand there and freeze up. But for other people, it could be a very different response. Okay, next slide, please. So this physiological response. So when trauma overwhelms our emotional regulatory system, the mind and body instinctively go into automatic survival mode, AKA amygdala activate, right? We become aware of any subtle changes in the environment. Some people have said to me, it's almost like a hypervigilance feeling that they have, that they've got to watch everything around them. There's a reaction to fast movements, a reaction to loud noises and sounds, a very high sensitivity to those things. And people will take those quick and decisive actions to protect themselves. It is not uncommon for me to hear somebody say, I'm just out of here, I can't take this anymore, right? They're making that quick response to what is happening and what they're feeling in the moment. The thing that's important for us to remember is that when that amygdala is going, so is all the adrenaline. And when the adrenaline is going, our body is at this heightened state of arousal. And when we have that heightened state of arousal, it leads to exhaustion and fatigue. And for many of our patients, those listening who know what that feeling of fatigue and exhaustion is, after you kind of felt like hyped up because either people weren't listening to you or people weren't understanding what you were trying to say, or you felt judged in the moment and that trauma was triggered, you have that adrenaline rush, and then all of a sudden your body kind of crashes. And that's because all of that energy, that heightened arousal was there. And then afterwards, there's that fatigue and exhaustion. And what's important to remember is all of that adrenaline flooding your body certainly doesn't help us when we're in a pain crisis, doesn't help us when we're feeling sick and in pain already. But this is kind of what happens, that emotional regulatory system is going to kick in when we don't feel like we're being heard and understood. Next slide. Then there's the psychological response to trauma. So I want to be mindful of my little word there, my two words, false beliefs. So I'm going to give you some context as to what that is, because let's be clear, there's a lot of stuff that happens to our patients with sickle cell disease that is not false. It is very true and it is very real. What we know about treating trauma, so let's take a step away from sickle cell, and I also am a therapist and a clinician. So when I'm working with someone who has trauma as a therapist, one of the things that we know is that when we go through any type of traumatic event, we tend to look inward and we start asking questions. Why is this happening to me? How did this happen? What did I do to deserve this? What did I do to have this terrible situation happen to me? And as we're trying to sort through and understand that, we can start to develop some things, some beliefs that aren't really true. Like, I don't deserve this, or not deserve this experience, but I don't deserve to be loved. I don't deserve to be cared for. I'm powerless. Nobody understands me. Nobody gets where I'm coming from. We kind of start to make these broad generalizations to try to make sense out of what is happening. And the truth of the matter is, some of that stuff is not true. There are some people that want to help us and that are on our side and do want to do the best for us and by us. But when we have been through so many bad events and so many repeat events of the same thing over and over again, it can be hard to turn off a lot of those thoughts and feelings that we have. But when we start to have that psychological response, for those patients that are on the line, think about that. Catch yourself when you're having those thoughts. And for our providers, recognize that if you hear some of this stuff coming from your patients, we need to slow down a little bit. We need to pay attention to the fact that, ooh, that's a trigger for trauma. Like, I can hear some of the language that is related to trauma here, and I need to make sure that my patient understands that I am here to help, I am here to support, I am here to listen, and we are going to slow down and work through this together. Okay, next slide, please. This slide, I think, is extremely important because there is the historical trauma of what we've been through as African Americans in our country, and even not just African Americans, but even for our Latin patients and the things that they've been through here in this country and continue to struggle with. But then there's also the medical stuff we talked about, and then there's just the trauma of having sickle cell. Just in and of itself is a very, very traumatic thing. Always worrying about pain and when it's coming, or if it's ever going to go away for that matter. The possibility of all the things that we know can happen with and related to sickle cell disease, whether it's organ failure, whether it's stroke, whether it's a shortened life expectancy, people not understanding sickle cell and not having any sense of patience and really being able, and expertise even, to care for our patients with sickle cell. People thinking that we're drug seeking because we're saying I'm in pain, and how do I express my pain, and how do I know that you'll trust me when I tell you that I'm in pain? People thinking that I'm attitudinal, or that I'm just an angry person, which is not true. People judging me on my pain. You don't look like you're in pain. Saying all types of terrible things. And then also understanding that sickle cell historically has not had the type of support that some of the other disease groups have had. And then the questions about a cure. So for our patients with sickle cell, it has its own very specific trauma as well. So when we think about historical trauma and we think about trauma-informed care, there's the standard way that oftentimes we have tried to treat our patients with sickle cell, and then there's the way that I want you guys to, this is what I want you to do, this is what I don't want you to do, this is what I want you to do. So when you think about the standard way, traditionally medicine has been very, and I always get this word jumbly, hierarchical, right? There's always been this hierarchy of I am the provider, you are the patient, I've had my training, I know what I'm doing, you are going to trust me, you are going to know that I'm going to keep you safe, and I'm going to tell you what you need to do, and once I give you this method of treatment, you go and you do that, and then report back to me and let me know how it goes, right? That has been the traditional way of care. The problem is that don't work. That's not going to work so well. That does not work, because think about what we just talked about. Think about the lack of trust, oftentimes, that exists with the healthcare system. Think about the fact that people have felt experimented on in the past, because it has happened. And think about the fact that not everybody knows how to treat our patients well. And so that standard trust being assumed, safety being assumed thought process is not going to fly. Instead, we need to think collaborative. When you think about a trauma-informed approach, it is a collaborative approach. And what I mean by that, it is a, hey, this is what we know to be the standards, right? Like, we know that drinking your water works well. We know that hydroxyurea works well for many of our patients. We know A, B, C, D down the list. With that being said, you tell me, patient, this is provider to patient, you tell me what has worked for you in the past. What hasn't worked for you in the past? What do you think about this plan of care? What about this you think is going to work well for you? And what might be some of the challenges for you? So it's this partnership type of process where the patient is actively engaged. They are participating in it. They're letting you know what their thoughts are about it, and partnering with you in this process. And recognizing that trust and safety is developed over time. I remember when I first started in the work of our adult sickle cell clinic, I just assumed, hey, I'm an African-American woman, my patients are majority African-American, they're going to trust me, it's going to be great, I'm a social worker, I'm good at connecting with people. I was wrong. It took some time. It took some time for my patients and I to connect. And what it was trust. It was, Melissa, you said you were coming back up to the room to visit me. Let me see if you actually do it. You said you were going to bring me these different approaches for me to try for relaxation. But did you do it? Did you really show up? They were waiting. They were waiting to see if I followed through on what I said I was going to do. And it took some time, but once that trust was established, we were able to develop some wonderful working relationships. But we want our patients to develop the skills that they need to advocate for themselves, to speak up for themselves, and to feel safe sharing with us. When we think about the trauma-informed care, some other things I want us to be mindful of. Remember when we talked about the physiological responses and that amygdala, that fight, flight, or freeze? We want to do everything we can to keep ourselves and our patients as calm as possible, right? We don't want to activate the amygdala. We don't want to create more stress. We don't need any more strain on their bodies than the strain that sickle cell has already created. And so we want to use calm, slow voices when we're talking. So often I've sat in the room with providers who are sharing information with patients, and it's coming out so fast, quick, 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 quick. And then the provider will say, okay, you have any questions? And the patient says, nope. And then they leave the room, and then I look at them and I say, you sure you don't have any questions? And I'm like, yeah, I don't understand anything that person just said. They were talking too fast, and that information was coming at me at 1,000,000 miles an hour. And so we have to just slow down a little bit and really make sure that our patients understand what we're sharing with them. We also want to make sure that we're not using judgmental language. You know, we don't ask things like, well, why do you do that? Or why are you doing that? That doesn't make any sense to me. No, you ask, can you help me understand that? I would like to hear your thoughts on why you don't think this may work or how you think this is going to work. It is much better, it creates more collaboration when we're careful about the language that we're using. We want to explain the reason for obtaining sensitive information. So I will tell you, as a social worker, I do my psychosocial assessments, and I get all up in people's business. I'm asking all types of questions that people are like, girl, why? Why are you asking all these things? And I tell them why I'm asking all these things. I'm asking you all these questions because I'm trying to get to know you as a whole person, not just as a diagnosis. I want to know who you are. I want to know who your supports are. I want to know who your go-to people are. I want to know the things that you're struggling with outside of sickle cell disease, because maybe there's some other supports that I can put in place. And so when we're gathering information, we want to be clear about what we're doing with that information and how we're going to use it. You also want to make sure that you've got private space to talk to folks. Not in the waiting rooms, not just anywhere where everybody can hear, but we really want to create that sensitivity and privacy for our patients. And even being mindful, if you're doing some inpatient work with folks, if a patient has other people in the room while they're here with us, you may want to ask, is it okay if I talk to you openly, or would you like for us to wait until it's just you and I? That way, again, because you never know who might be in the room with the patient and whether they feel comfortable having all of their information shared with the folks that could be visiting with them. So just something to kind of think about. And then also consider the patient's physical and emotional barriers. So I'm going to tell you guys a couple of stories because this one is, they kind of help you understand some of the barriers. So I had a patient who, in hindsight, I knew that he had a lot of current trauma as well as historical trauma. And he was inpatient at the time. They were going to make some changes to his pain management because what we were doing wasn't working for him. But it would mean kind of pulling him down off of some things and pulling him up on some other things. And I knew he wasn't going to take that information well. So it was myself and a provider and 2 of our APPs, and I knew my friend quite well. But my providers went into the room, and he was sitting on the back side, so the furthest away from the door, close to a window in a chair. And the providers went in and made like a semicircle around him. And I was like, ooh, that is probably not a good idea because you're going to make him feel kind of boxed in and closed in that way. I stayed by the door, but before I could kind of like help rearrange the room, they just kind of dove into their conversation about the changes that they were going to make. And when the doctor saw that my patient was getting frustrated by the information being shared, in his heart he was trying to do the right thing, but very quickly he just bent down to the ground and to get to eye level with the patient. Remember, the patient was sitting, and that sudden movement triggered the amygdala. I mean, the patient was already boxed in. They had just heard news they didn't want to hear. And then this very sudden movement happened. And the patient assumed, or based on his reaction, he assumed that he was now being threatened. And so the patient jumped up, grabbed his IV pole, and reared his fist back. It was about to swing. And so I immediately cleared the room, got everybody out of the room, and spent time just helping that patient to regulate down, to calm down, and to work through what he felt and experienced in that moment. Now, I also had a conversation with the providers to say, we don't do that, y'all. This is not how we do this. But I was able to work with that patient to help them calm down. So you want to be really careful about those physical boundaries, being really mindful to not have people feel boxed in, not to make those sudden movements. And eye contact is another one. I had a patient who was a refugee from a country in Africa. And when I was doing my psychosocial assessment with her, again, I was getting all up in the business, asking lots of questions. And I noticed that she would not make eye contact with me. And as a social worker, of course, I'm just staring at the poor woman. So I took her cues and I put my head down and I put my pen and paper down, and we just stopped. And the more that we talked and the less that I made eye contact with her, the more she opened up. And it took me a minute to get my skills right and to pay attention to what was happening in the room. But I was able to work within her boundaries and create a space that felt safer and more comfortable with her. So I'm saying to you all, especially to my providers, pay attention to what's happening around you. Your patients are giving you cues and clues. And so if you can just take your time and pay attention, you can figure out a whole lot of stuff in the moment without a person even having to say it to you, okay? And then also recognize that touch can help some people to self-regulate, and others, it can be a trigger. And so that's somewhat of a trial and error, but it's also a thing where you can ask. You can ask the person. I will always say, is it okay if I just, hold your hand right now because I can tell you're in a lot of pain? Or is it okay if I just sit here? Would you prefer for me just to keep a little space or distance? You can ask and figure those things out because it's going to be different for everybody. Okay, so some other things. Do not take things personally. I don't know about you, but I have been in pain in my life. I don't think I've ever had the amount of pain that our patients with sickle cell experience. But even with the pain that I've had, number one, I am not always the nicest person when I'm in pain. I try to be, but I'm not always there. And certainly when I've been triggered or I have felt like people haven't heard me and haven't understood me or have been unkind towards me, then it is fully possible that my amygdala will kick in and I might say or do some things that aren't the kindest things in the world. What I have learned as a provider is that when folks have lashed out at me, it's not personal. And it's my job, it's my ethical duty as a provider to recognize that oftentimes it isn't even about me, what's going on in that moment. Now, if I did something that triggered something, then I do need to apologize and I do need to own up to it. But if I walk into a room and a person is upset, 9 times out of 10, it had nothing to do with me because I just got there. And so my job is to help them regulate themselves as best as possible or give them the space and the time that they need to regulate. It is not okay for me to lash back out as a provider, right? we have to be thoughtful about that, and we as providers have to use good emotional intelligence, or they call it EQ is another term. And for my patients also, again, no judgment, right? I fully recognize that when we are in pain, all types of things can happen. But once we're able to self-regulate, it's okay to go back and say, you know what, I lashed out at you and I'm so sorry. I was just in so much pain, or I didn't feel heard, or I didn't feel whatever. It is okay. We just all have to do our best to be and take responsibility for our actions, and to be as kind as we can be in those moments. But we all have to operate with good emotional intelligence. Don't be afraid to have hard conversations, right? About race, about fears, about false beliefs, about opportunities, like whatever it is that is in the room, let's have a conversation about it. I know some of us feel more comfortable than others. I'm a social worker. I call myself an emotional firefighter. I run into emotional situations and have no problem doing that. Other people, it's like, that's not my jam. I don't feel comfortable. But you know, if you feel comfortable, have those conversations, engage with folks in that way. I promise you it'll draw you closer together as opposed to pulling you further apart. And listen for those generalized statements, things like, you know, you're that nice nurse compared to the other ones, or you're that nice provider compared to those other folks. Tell me why, what's different, you know, digging in and trying to find out those things. And then again, just gonna take a quick sip of water. Pay attention to strengths, right? We're trying to build relationships with our patients. And there is no better way to build a relationship outside of trust. That's number one. But number two is to say good things about people, to connect with people, to find things that are important to them and to join around those things. If there's a shared thing that you and your patient both enjoy, find ways to acknowledge those strengths and those good traits and partner with folks around that. And say it out loud. It's a really helpful way to connect. Next slide. So this is just a quick slide on emotional intelligence. Again, I tell you that it is our responsibility, our ethical responsibility as providers, and honestly, even for our patients, as best as we can, to engage with our care teams in a way that helps us to really join and connect. But when you think about emotional intelligence, there's really 4, now 5 quadrants to emotional intelligence, but it's really your ability to know yourself and your feelings, your ability to read the room and really understand other people's feelings and emotions, how to hold both of those things together in the same space, your stuff and someone else's stuff, and then how to regulate emotions when you're in these spaces. And the last quadrant that's not listed here is kind of brand new in the EQ world, but it's self-motivation. So our ability to get things done and stick to plans that we make. Okay, next slide. So now for our last few minutes, we're gonna take a little bit of time to look at a few cases, because sometimes everybody has their own learning style. I know mine is an experiential learning style, so I kind of need to see something play out for me to really understand. So this is a case of a 50-year-old African-American male. He had SC. He also had active acute pulmonary embolisms. He had renal failure. There was polysubstance use in his history, not current. Only thing that was on his toxicology screen at the time of intake were opioids that were prescribed. And when the call came through to me, this is what was reported, that this patient was angry, easily agitated, cursing, violent and fighting with staff, not trusting of staff, pushing people away, did not want their help, hypervigilant, always on guard, and a nurse, her exact quote to me was very prickly. Before you move to the next slide, I want to say that, one, I apologize to any patients that are on the call, because it probably is traumatic in and of itself, hearing a patient described in this way. So I want to be sensitive and mindful of that. I also fully recognize that when folks do call for support for some of our patients. Unfortunately, these are some of the terms that are used. So again, just my apologies to folks, because again, I would imagine that that could be triggering to you. What is interesting about this, now we can move on to the next slide. When I spend time with my patients and when people tell me that laundry list of behaviors, number one, I automatically recognize that there's trauma, right? Because all of that was amygdala stuff, all of the pushing people away, the anger, the frustration, the hurt, all of that to me is an immediate, like I just dismiss all of the sort of language that was being used and I hone in on the trauma piece of it. So when I go in, my whole goal is to, one, help calm the patient down and get to know who they are, because that is something that unfortunately doesn't happen enough in my book, in my mind. And so he and I spent quite a bit of time talking the first time that we met. He was homeless, he was staying with a cousin, but I learned that this was not always the case for him. He lived in another state previously, had an amazing job, made good money, had owned his own home, was doing extremely well. But unfortunately, he got laid off. And it just so happened that he had done so well at his job that he had made a lot of advancements into leadership and management. But unfortunately, his education didn't match his skill set. So when he started looking for another job, he couldn't find one to match the level of income and the quality of job that he had before. And it just kind of led his life into this sort of downhill spiral from there. He ended up losing his home. He, unfortunately, drugs was a way that he could gain some of the money from the loss of income, and that just led to not only the using, but then also the selling of it, and it just created all types of chaos for his life. He ended up being arrested again because, unbeknownst to us, there was a warrant. He served his time, and what ended up happening was he was released from jail and then came back to Duke. And he came back. He was in our hospital. We actually found him out front in our emergency department. I was checking my daily census and I saw that he was back. And so I immediately ran up to his room to go see him. And one of the nurses stopped me and she said to me, "Don't waste your time seeing this patient." And when I tell you I wanted to do a swift roundhouse kick to the throat, I did not. I kept my amygdala in check, and I let her know very firmly that no one is a waste of time and that I absolutely am going to go see my patient. And so she stopped me again and said I couldn't go in because he was having an x-ray. And I did look in and I saw the x-ray techs doing their thing. And thankfully I caught his eye. And he kind of gave me the little head nod, and I gave him a head nod, and I mouthed that I would come back to see him. And so my day got busy. I didn't get to go back that afternoon. The next morning, I came in, checked my census again, and I didn't see him on the census. And I got very flustered, and so I, again, kept digging, and I found out that he had passed away that night. And it was one of the hardest losses that I had ever experienced because I couldn't comprehend why he left prison and came back here. He was states away, but he came back here to our hospital. And I thought about it, and I happened to be a praying woman, and I prayed about it, and the thought occurred to me that he knew he was sick, because we know for our patients when they have sickle cell, jail, prison is the worst place for them to be. So he was very, very sick when he got back here. And I have a strong feeling that he wanted to be someplace where somebody cared for him. And even though that particular nurse was not caring for him in the way that I would have liked, I think that he knew that I would have advocated for him, that others of our providers would have advocated for him, and he wanted to be someplace where he felt safe. And so I say that to all the providers on the line because, number one, this whole training was based on him. I created this because I never wanted another patient to go through what he went through, but also because we just never know the impact that we can have on a person's life when we can slow down and recognize that even if there are behaviors that we prefer not to see, the reality is that if we can connect with someone, we can get those behaviors to come down. He never did any of those things with me. He did it with people he didn't trust and people he didn't feel safe with. But when he found someone that he could trust and be safe with, all of that melted away. And I'm a firm believer that when we can care for people the right way, we can regulate all types of things in the lives of folks. We can find a way to connect. We can find a way to join with them and partner with them and provide them the care that they need and deserve. So this is in tribute of him. Our next slide, please. My next one is for a 23-year-old African-American female. And we often know that sometimes it is not just our patients, but they often have their families with them. This was a young woman who had sickle cell SS, acute respiratory failure with hypoxia. She also had a dual diagnosis of sarcoidosis. There was sepsis, and poor thing had been in the ICU twice in the past 6 months. The patient and her mom were very distrusting of us as staff. Had a hard time accepting the care that we wanted to be able to provide. There was a lot of sort of blame going back and forth about what we were doing and not doing. There were some measures we wanted to take to preserve life, but those measures weren't, the family were not agreeable to that. And then the belief that the staff was not capable or knowledgeable. And there was a lot of volatile interactions between the staff and a lot of what was termed rigid thinking or having a hard time to think about things from different perspectives. Again, apologies for how that psych presentation is presented. When I spent some time, I heard mom say some things that immediately again triggered that trauma for me, that they're just experimenting on my daughter. There was some ideas that our APPs or our nurse practitioners and PAs couldn't provide the right type of care, that only the doctors could do that. And I will say that I have done some great APPs and PAs, by the way, and so you got to be careful because there's a lot of people who love to take care of our patients and are actually really, really good at it. The family was convinced that we were trying to hurt her daughter, and there was some misunderstandings about pain and respiratory function. Pain medicine and respiratory function. So there was some education that we had to do to really help mom understand that by increasing pain medicine when somebody is already unconscious is dangerous, and we did not want to stop her daughter's breathing, and that the patient and mom were really struggling, even post-recovery. There was a lot of struggles there. And so I spent a lot of time with this mom, and when her daughter was able to be awake and conscious, really just talking with both of them and really doing a lot of just education about what was happening, trust building, rapport building between them and the care team, and then ultimately working with the daughter, because even though mom was very present and very active in her daughter's life because of her love for her daughter was an adult. She was 23. And yes, she was in that sort of transition age for sickle cell, but she was an adult. And we talked about hearing from the daughter what she really wanted and what type of care was important for her, what she was comfortable with and not comfortable with. And I will say there were some challenges because she and mom disagreed on some of that, but there's certainly, we spent a lot of time just kind of processing through that. Next slide. So as we think about our patients, remember I told you that relationship building and strength building is a huge piece. when we think about our patients with sickle cell disease, one of the things that I loved the most about my patients were their strengths and the great things that they brought to the table, the resiliency, the stuff that our patients overcome on a day-to-day basis, the stuff that we put them through, the stuff that they deal with outside of the healthcare system. I can't even begin to imagine how our folks do what they do, but they are so resilient. A lot of them have strong faith backgrounds, have strong beliefs, strong family values, the kindness and the giving. I love to see my patients on the units running back and forth, visiting each other when someone felt better and they knew their friend was down the hall still struggling, you know, taking snacks and going down and holding their hand and just being with each other. The kinship bonds, the real and the fake ones. It was nothing for me to be Auntie or Cousin Melissa and not just the social worker, and I was completely okay with that. The rich and lively affect, and then the humor. Oh my gosh, we laugh so much. And so I appreciate that so much about my patients. All right, and I think that is it. So I am open to questions. I saw one chat question about getting a copy of the PowerPoint. Please, please, please share it. You are more than welcome to have it. And then I will answer any other questions that you all may have for me.
Wonderful. Thank you so much, Melissa, for your presentation. I personally found it to be not only informative, but just very powerful with the storytelling and case stories, as well as impactful. And so I know other folks on the line have feel the same way. At this time, we will begin to take participant questions. So as a reminder, we will take those questions through either the chat box function or the question function on the control panel for this webinar. So with that, I will turn it over to Jackie.
Thanks, Niani, and thank you, Melissa. That was, I want to just thank you for presenting on that topic and sharing your experiences, and also just for the thoughtfulness and compassion you bring to this work. As we kind of wait for some questions from our participants to come in, I actually have a couple questions. The first one is just this idea of like, how do you practice a lot of this trauma-informed care in settings like the ED setting or settings where it's a lot more fast-paced? Like, how have you seen that successfully work? And if you can just tell us a little more about that.
Yeah, great question. So one of the things that I've really appreciated about the role that I had as the social worker that took care of our adults here is that I was given full permission to follow my patients anywhere. So I did a lot of trips down to the emergency department when folks came in, because really I think that's one of the most critical spaces, because that's when our folks are in acute pain, and sometimes depending on, you know, the triage nurse that's screening and then the providers who are seeing them, some people, you know, are sickle cell champions and get it and understand it and are able to jump into action and provide that support, and other times they're not. And so my role was to come in and check in with the patients. Are you getting what you need? Are you feeling any better? Or did we immediately start your care plan? All of these things. And if not, if I could go to those providers and say, look, care plan, this tab in the medical record, can we please get started, because the pain is severe and we need to move. And really, if the patients weren't getting the care that they needed and that amygdala was kicking in, then it would be my job to also just do some of that trauma-informed care of helping them to regulate down those emotions, be able to share in a more appropriate way what they're feeling, what their needs were, and then even being a liaison back to their hematologist to say, hey, can you call the provider in the ED and let them know to activate this care plan, make this happen. So kind of being an advocate and a voice for our patients when they were in too much pain, perhaps to do it for themselves, was another way specifically in the ED that was really impactful. But it was really just being there with them and making sure that they felt heard and understood.
And kind of a follow-up to that, question from one of our participants is, have you recommended to providers that they learn more about trauma-informed care? And if so, kind of in what ways were you able to get that across kind of most successfully?
Good question. And yes, I have spent a lot of time. Like I said, this training was created for my friend who passed away. And what I did was I created this and then I started teaching this first to the bedside nurses, since, nurses were saying some things that I didn't appreciate at all. And then I then moved on to the providers and then throughout the health system, both here at Duke and nationally, anywhere I get a chance to share this information, I do. But I've probably given this same training close to 100 times now. It's a lot, and I will do it 100 times more if that's what it takes. But it was something that I kind of rolled out, and I believe that it's just as important for them to hear this as it is for the providers, because your nurse is the one you're going to see more than your providers, and so it's important that that they all hear it. But yes, I will give this information to anyone that will, to anybody that will hear it. Thank you for that question.
And I'm going to jump in real quick. I know there's a couple other questions from participants, but just as we're on that topic, have you found that you need to do some type of like organizational culture change to kind of embrace this approach, or is it enough to kind of go provider to provider?
Ooh, that's a good question. I mean, let's be clear. I think historical trauma plays out even outside of our sickle cell population. I think it plays out for all people of color who feel that they are not being heard or understood. We know, for instance, the painfully high rate of Black moms trying to deliver and have children not feeling heard, not feeling understood. I mean, it goes well beyond sickle cell, and I would love for there to be systemic change in healthcare in how we understand and relate to patients of color. And I have taught the same thing in a broad sense, not just looking at sickle cell, but really just looking at all of our patients of color, and not just African American, because let's be clear, within our Latin community, within our Native American community, there's also been some really horrific things that have happened in healthcare. And so I do feel very strongly that there should be a systemic approach to how we care for folks within medicine.
Thank you. And another question from an attendee is, do you feel that there is also trauma from pain and hospital experience in infancy? The first pain crises as an infant usually involves several needle sticks to get an IV and pain medication administered. Do you feel that that trauma does not attach to a memory play a role in response to hospitals?
That is a great question. Oh, deep. Yes, as far as I know, there has not been research on that. If it is, I haven't seen it. But I would say absolutely, because even when you think about childhood abuse, traumatic abuse as a child, not that, going to the hospital and having to have needle sticks and blood draws and all is abusive, but it is traumatic for a small child. It is scary and it hurts. And the pain of sickle cell, all of that. I do think that there's something there, but I don't believe there's been a lot of research or understanding about the impact of that. That's a great question.
And participant just wanted to thank you for sharing the message on multiple levels of care providers. So thank you for that. I have another question about what your experience or thoughts are about what role telemedicine or telehealth has made on kind of being able to do this trauma-informed care with the patients.
Yeah, that's a really good question. Again, I don't think there's literature yet, because I would say that since 2000, when we really started after the pandemic, we really began this process of really digging into telehealth. I think in some ways it has helped and perhaps even caused some issues. The help is that our patients don't have to get out of bed if they're not feeling so good, travel, getting to the extremes of weather, extreme hot, extreme cold, parking, walking long distances to their clinic visits, etc. I think that that's been a benefit in that way of helping patients. And let's also be clear, we feel safer at home as long as home is not a place of harm or danger for us, right? So when we feel safe and we're in a safe space, we may be more apt to open up and to share and to feel comfortable. Whereas walking into a clinic or an emergency department or something like that can kind of trigger its own trauma. And so I think in a lot of ways, telehealth has been helpful. It may not be as helpful when it comes to perhaps being able to capture all of the nonverbals and the body language as a provider. Now, again, I'm a social worker, so I'm all about the nonverbals, which is why it's hard presenting when I can't see y'all's faces to know whether my jokes are landing or not landing. I kind of like to see what is happening with the person. And even if there's a video, chances are I'm only seeing like, middle of chest up. I'm not getting your hands and your hand movements. I'm not catching whether, your body language is crossed or uncrossed. All the things that I pay attention to really read what is happening with the person. And so I think in some ways, some of those nuances and even the personal connection is not the same with telehealth. So again, I think it's kind of a 50-50 split. I think for some patients, it might be just right. And for other patients, it might not be the best fit for them.
Thank you for that. I'm going to open it up to any other further questions from our participants. We have a lot of thank yous for the excellent coverage of kind of the sensitive topic and just what a great job you did on presenting that to us. I'll give folks a few more minutes to see if they have any more questions.
Okay. And also, you guys have my contact information in the slide deck. Do not hesitate to reach out. I am happy to connect and offer any type of help or support or guidance or whatever you need. I'm here to help as much as I can.
Also, as we give it another moment, I also have put my email, nyani.coker@trackingcalifornia.org there, so you're welcome to email me. This platform will automatically send a copy of the recording to you within a week or so, but you're welcome to email me for that as well.
Okay, I think that looks to be it. We have a lot of thank yous coming your way, Melissa.
Oh, I'm so grateful. Thank you all for giving me the opportunity to be here. I appreciate it.
Oh, of course, we appreciate it as well, and I'll definitely pass those thank yous along and comments. Jackie, did you have anything else?
Nope, I think that's it for today. Thank you, everyone, for joining us here.
Okay, awesome. Well, then this concludes the time for our Q&A session. I have up on the screen right now all of the ways to get connected with the California SCDC program. We now have our new code, so hopefully you can scan it to your phone and it will pop up with our website and kind of some of our social medias and the different ways that you can stay in contact with us, as well as get on our listserv to receive our newsletter, which comes out twice per year, as well as our webinar details like this. So I want to thank everybody for their participation and their time. Upon ending this webinar, there is a brief 3-question survey where you can provide feedback about the webinar, ask some additional questions for myself or the speaker, and suggest future speakers. So that would be great if you could take a moment. We would greatly appreciate it. Melissa, thank you so much again for your presentation. And thank you to everyone who participated today in joining us. We appreciate you being here, and we will talk to you next quarter. Thanks all. Bye-bye.